Good evening and welcome to the final week of the 21st Annual Mini Medical School Program. Again, my name is Dr. Richard Colgan. I'm a professor of family and community medicine at the University of Maryland School of Medicine. I'm also the executive vice chairman in our department and executive director of the Mini Medical School Program. Last week, we were joined by 4 of our faculty members here at the School of Medicine. Dr. Jenny Law from the Division of Hematology and Oncology presented on sickle cell disease. Then we spent the remaining hour engaged in a rich discussion on health equity and social justice with 3 faculty panelists, Dr. Laundette Jones, Dr. Anik Forrester, and Dr. Maureen Black. That was good. This evening, you'll be hearing from 2 of our esteemed faculty members, and we have a few special guests who will be joining us at the end of tonight's program. But before I introduce our speakers for the evening, Ms. Robinson will share a few reminders. Ms. Robinson.
Thank you, Dr. Colgan. Good evening, and again, welcome to the final week of Mini Medical School. Everyone should have access to the e-course manual. There you will find this evening's electronic course materials in the week 5 folder. Also, please keep in mind that we will be taking questions at the end of each discussion. Our presenters will spend the last 5 minutes or so taking questions directly from the chat box. So please be sure to insert your questions while the presentation is in session. Or if you prefer to ask your questions audibly, please raise your hand if you would like to unmute yourself. And finally, we will wrap up this evening with our mini virtual graduation ceremony. That being said, each of our faculty members are prepared to present for roughly 35 minutes to allow time at the end for our closing presentation. We have a very exciting evening planned, so let's begin. Dr. Colgan will now introduce our first speaker for this evening.
Thank you, Lauren. So it's my great pleasure to introduce Dr. Joseph Martinez. Dr. Martinez is an associate professor in the Department of Emergency Medicine and the Department of Medicine at the School of Medicine. He completed his medical school and a combined residency training in emergency medicine and internal medicine here at the University of Maryland. Dr. Martinez currently serves as Associate Dean for Medical Education and Student Experience at the University of Maryland School of Medicine. In addition to his clinical and administrative duties, Dr. Martinez is an active lecturer on the local, national, and international level with a particular interest in abdominal and gastrointestinal emergencies, as well as medical student education. Here to present on the new Renaissance curriculum, Dr. Joseph Martinez.
Thank you so much, and welcome to everyone. Again, congratulations on reaching the last night of your mini med school. I'm excited for all of you to have your graduation ceremony tonight. I'm sure you're thrilled to be at the end, and it's quite an accomplishment, and I hope you learned a lot during your weeks here. Dr. Colgan was nice enough to ask me to come and talk a little bit about how we educate our young physicians in this day and age, and some of the changes that we've made along the way in how we do that. And so I'm going to walk you through a little bit, and I'll talk a little bit about my own personal journey to medicine as well, and how that's changed for our new generation of physicians. So let me go ahead and share here. Is everyone able to see my slides, I hope? Rich, you okay there? You can see. Thumbs up if you can see.
Dr. Colgan, I'm sorry, Dr. Martinez, it looks as if it's in, it's not in presentation view.
There we go.
Okay, is that better?
Yes,
yep.
Thank you.
Great, thanks for that heads up. I appreciate it.
Absolutely.
As Dr. Colgan said, no matter how many times you do it, technology always manages to grab you at the end. So anyway, thank you for bearing with me, everyone. We're going to talk a little bit about what we here at Maryland call our Renaissance curriculum, which we launched just a couple of years ago. We had been planning it for a number of years, and then it came to the time to launch the new curriculum, and we were struck by COVID, as was everybody else in this virtual room. But you get to a certain point where you're committed to a pathway, and you have to push forward. And as the billboards say, the only way is through. And so we continued to go ahead with our launch and went ahead and launched our curriculum last year in the middle of COVID. And I'll talk about some of the challenges that led to as well. But when we thought about our Renaissance curriculum, we really wanted to start with what the goal was and what we wanted our students to graduate with, and how we wanted them to go out in the world and represent the name of our medical school and take care of the citizens of Baltimore and Maryland and beyond, all the way to the far borders of our country, where all of our students have gone through various years. So when we thought about that goal, what we really wanted to do was to train our students to be lifelong learners, because medicine is changing so rapidly. As you've probably heard over the last couple of weeks or couple of sessions, things that we learn, rapidly evolve, whether there's new medications to treat it or there's new diseases like COVID that we have to learn how to deal with. You can't just graduate now and feel like you've learned everything that there is to learn. You have to find some way to be able to keep up with the changes in medicine. So we want those graduates to be excellent, but also still possess those things that we look for when they first arrive here in medical school. Those humanistic tendencies to be highly professional, really to go out in the world and be leaders and be critical thinkers, but always be paying attention to things like social justice and diversity. So I was glad to hear about your session last week, where it sounds like you had a pretty robust discussion about healthcare inequities, which has been a topic on many of our minds over the last few years, and has been really highlighted by this pandemic. So just want to walk back a little bit and talk about how one actually becomes a doctor, because even my own children don't seem to understand this, and they ask me, sometimes, well, Dad, what does it take to become a doctor these days? So if you go all the way back and just think about, graduating from high school, it usually takes about 4 years to graduate from high school, and then students will go on to college for 4 years, and then they come to med school. So many of our students will take some time between college and medical school to do other things, but some of them come directly to medical school, and medical school lasts about 4 years. This is the most typical pathway. And then congratulations, at the end of medical school, you're a doctor. But with that certificate, you really haven't reached the level of training where you can go out and care for patients all by yourself. So you've acquired a lot of knowledge and a lot of skills through medical school, but in order to really care for your patients, you have to undergo some additional training in whatever field of medicine you're going into. So students or doctors at this point will traditionally go on and do what's called a residency program. And that is a sort of specialized training and can last anywhere from the shortest being 3 years to one of the longer ones being 9 years. And at this point, you're really learning what type of physician you want to be. So Dr. Colgan is a family physician. I'm an emergency physician. You can think that there's many other specialties like surgery or OBGYN. And that's where they really learn, these new graduates learn the nuances of each discipline of medicine that they're planning to pursue. As physicians become more and more specialized, there are new opportunities for further training. So let's say that you've graduated from medical school, you've become a doctor, you've graduated from a medicine residency, so you take care of adult patients, but you decide that you want to specialize further and become a heart doctor or a cardiologist. Then you would do what's called fellowship training. And fellowship training can be anywhere from 3 to 5 years after that. So it can be a long road, but it's a road that is really full of wonder at every step of the way. I mean, it's incredible the things that you learn and the people that you get to meet and the patients that you get to care for and work with. And it's very rewarding at each one of these stages. So what does our medical school look like? So it's very challenging to get into medical school these days. Our class last year, our entering class had 150 students in it. And the Office of Admissions received over 6,200 applications for those 150 spots. So even just to make that sort of first cut is pretty is quite an accomplishment for these young students. Our Office of Admissions has really paid a lot of attention to trying to increase the number of students that start here at Maryland that are underrepresented in medicine, and that means those racial and ethnic populations that really don't have the same representation in the medical profession when you look at the number of those people that are in the general population. So, if you look at a Black male, they may be very underrepresented in some of our medical school classes. So our Office of Admissions has really been trying to be diligent about reaching out to different parts of our community and our state and encouraging people to apply to medical school, helping them through some of our pipeline programs to envision themselves in medicine. And they really started to see some dividends in that. So the number of underrepresented in medicine matriculants or people that started medical school last year was 31%, which is one of our highest percentages ever. So certainly we're improving, but still have a long way to go. Students of color identify as 62%, and you can see the definition of what students of color is at the bottom of the screen. Those who identify themselves as Black, African American, Asian, South Asian, Middle Eastern, Pacific Islander, Latinx, Chicanx, or Native American, or even multiracial. So 62%, LGBTQ, 10%. Really, since I was a medical student here in the 1990s, our medical school classes have been predominantly women. So my class, when I graduated in 1998, was 60% women, and now it's 67% women. So we've really done a good job of encouraging women to apply to Maryland, accepting them and helping them enter the medical professions. Being a state school, the majority of our students are from in-state. And when you look at how many students then go on to residency programs, about 99% of our students will end up matching into a residency program. Now, I wanted to talk a little bit about what medical school used to look like. And I graduated back in 1998, so I started medical school in 1994. My wife, who is also a physician, was in the same medical school a couple of years ahead of me. And so I wanted to talk to you a little bit about what her experience in medical school was like, and then tell you what my experience was like, and then use that to tell you what our current experience was like. So when my wife was in medical school, she took a number of classes concurrently, meaning she took them at the same time. So for instance, maybe from 9 a.m. to 10 a.m., she would take anatomy. And then from 10 a.m. to 11 a.m., she would take biochemistry. And then in the afternoon, she might take genetics, or she might take pathology. And she was in class, sitting in the lecture hall from 9 a.m. to 5 p.m. every day. And then she would go home and she would study all the material that she had learned during the day till 2 or 3 in the morning, and then come back the next day and do that again. And she would have a test about every week. So it was a test in one of those different subjects. So maybe one Monday she might have an anatomy test. The next week she might have a biochemistry test. The next week she might have a genetics test. So she was always sort of felt like she was on that hamster wheel where she was running in place and trying to keep up as much as she could, but always in danger of falling behind. And that lasted for about 2 years, and then she would move ahead and do 2 years of additional learning in the hospital working with patients. Now, the first change occurred when I was a first-year student. So I was the first class of what we called the new curriculum then, and that was the last major change before the one that we had last year. So in 1994, we changed to what we call the block system, meaning that we weren't learning a bunch of different classes all at once. We learned a couple of different subjects at the same time. So for instance, I learned anatomy, which is sort of the structure of the body. And I learned histology, which is the microscopic structure, looking at things through a microscope, and embryology, which is how the body develops. I learned all of those as one block, and I was able to just focus on that for the period of time that I was learning it, and then I would have a test on that. And that was really helpful. And so I wasn't always studying for an exam in a different subject than what I was learning. And importantly, we had started to realize back then that maybe lectures are not the most efficient way for people to learn. And so we decreased our class time. So I told you my wife was in lecture from 9 to 5 every day. I was in lecture from 8 a.m. to noon. And then I had afternoons where I could study and do what we called self-directed learning. And I learned all of the normal parts of the human body in my first year of medical school. And then in the second year, I learned all of the things that could go wrong. All of the disease processes, et cetera, that could go wrong. And then after that, I sort of had a very similar curriculum to my wife, where I entered the hospital and spent 2 more years learning from patients and from physicians in the hospital. So what were some of the drawbacks when I was in medical school? Well, some of them were, you can imagine, if I learned normal in my first year, let's say that I learned the normal structure and function of the heart in August of my first year, and then I learned what could go wrong with the heart in December of my second year. That's a pretty long period of time, and I would have to go back and relearn a lot of the normal parts before I could really understand the abnormal parts. Importantly, there was very little clinical work, we call it, where that means work with patients in those first couple of years, where I was really just in the classroom learning from books. And there's a lot of pressure to learn to to sort of decide what kind of physician we were going to be when we graduated, and in a very short time period. So we decided that, after a number of years, that it was time to make a change. And what were the things that really pushed us to make those changes? Well, one is learning is different now. When I was a medical student, we didn't have the internet, which I know is hard to think about, right? For those of us that are, we're all on the internet right now, but trying to learn without the internet was a very different time period. So, I had stacks of books and I had index cards and things like that, but my students now, they come in and they're so well versed in different ways to learn. So not only is learning different, the students are different now. My wife and I joked that when we were in medical school, we didn't know where the administration offices were, and we would never think about going to talk to people and saying, why are we learning this, or why are we learning it this way, and things like that. And students now, they're much more inquisitive, and they're much more willing to come talk to me and say, Dr. Martinez, why are we learning it this way? I have friends at other medical schools that are learning it this way, or when I was in college, I learned things this way, or explain to me why we have to do this. And that's really great, because they bring lots of great ideas with them. And it helps keep us from being stale and doing the same thing over and over just because we got used to doing it. So that inquisitiveness that students bring with them, I think, has been really helpful for us in being better educators. And we know more and more about how to teach and learn effectively. And like I said, it's really not sitting in a lecture for 8 hours or even 4 hours. We know that sitting here, listening to material passively is really probably not the best way to learn it. You learn things best by talking about it and by doing things and really sort of involving yourself in those types of things. So what were some of the changes we made? Well, we moved to a model where our students work more collaboratively with each other. So perhaps they get into groups and we say, you're taking care of a patient who has these symptoms. Now work together in your group to figure out what could be causing those symptoms and what do you think that you could do about it. And as faculty members, we work with them as facilitators rather than simply just lecturing to them and telling you, if you have this symptom and this symptom, it means this disease process or it means this ailment. We help them work through the approach to sort of those things, and that really helps embed that material in their mind a little bit better. We also know that even in those early phases of learning, if you can relate the material that the students are learning to a patient that they're going to be caring for in a few years, the material really sinks in better. So you'll hear from students, why do we have to learn all these complex biochemical pathways? Why do we have to learn all these different medications? But when you help to relate those medications or those pathways to a patient that they're going to be caring for, they really then can put A and B together and it really sticks in their mind a little bit better. So even in those very first days of medical school, we really try to relate everything to a patient that they're going to be caring for in a few years. We haven't gotten rid of lectures completely. Some medical schools actually have. We've kept our lectures, but we've tried to make them shorter and a little bit more engaging. So instead of maybe 2 hours of lecture, maybe in that block of time, what we'll do is we'll have a lecture for 20 or 30 minutes, and then we'll have the students, break off for just 5 or 10 minutes and talk about what they learned, answer a couple of questions, and then come back and we'll move on to another topic and do some more lecturing as well. We do some more innovative learning. So again, it's much easier to actually learn by doing than it is to learn by just hearing about it or by reading about it. So we do a lot of things, as you see with this mannequin down here, with simulation, because we want patients to be safe while we're learning. So the students learn by doing things on mannequins. They learn by doing things through virtual cases, and then after that, we expose them to patients that they're actually in the hospital. So a lot of innovative learning as well. And importantly, I say that with every change, there's got to be at least 4 or 5 new committees. And so this is one of the new committees that we started when we started our new curriculum last year. And it's one that I'm really proud of. It's called the Educational Content Review Committee. And it's a big fancy name, but what it means is that there's a group of educators that look at every piece of learning material that the students are going to be exposed to before the students see it. And the review comes in a number of different layers. So the first one is simply, is this the best way to present this material to the students so that they learn better? So we try not to have PowerPoint slides that have 1,000 words on them and 12 tables, and the writing is really tiny and they can't see it. We try to say, is this an important concept that they're going to need to know as a physician, or is this just, extra stuff that we're putting on there to make the slide look more complete, right? So that's the first level of review is really just basic sort of educational review to make sure that it's effective as a teaching tool. The next level of review, though, is the part that I think has made a real difference in our curriculum, and that's our diversity, equity, and inclusion review. So we have a wonderful set of reviewers that really looks at all of our materials before we release them to the students, and they're looking for a number of things. One of the problems that we've seen for decades and even centuries is that there's a lot of bias in medicine. That's no surprise, right? Everybody knows that, and that, just like there are in many other fields, there's a lot of bias, and whether it's stated outright or whether it's just because that's how it's been for many years. So for instance, one of the things that we noticed as we started looking through all of our materials is that oftentimes the pictures that we would use of rashes and things like that would always be shown on people that had light or white skin. But when our students go into the hospital, our hospital is here in West Baltimore, and about 76% of West Baltimore identifies as Black or African American. So if you're learning a disease process like there's a disease called lupus, where one of the ways that you make that diagnosis is by identifying a characteristic rash that a patient may have as a presentation of lupus. But if our students have only been exposed to pictures of that rash on white skin, when they see somebody that has a different skin tone, they may not recognize that rash. So the second level of our review process is to make sure that we're representing all of our patient population, making sure that students are able to identify things in all of our patients, regardless of what their race or ethnicity is, as well as addressing some of those healthcare disparities. So trying to say, if a disease process is more common in a certain group of people, well, let's dig into that a little bit. Let's understand why that disease process is more common in that group. Is it because there's less access to healthcare in that group, or there's less access to medication that could be used to prevent this from happening? So rather than just saying, well, this disease is more commonly seen in this group of people, we really try to delve into some of the underlying reasons why that occurs, so that students can have an understanding of that, and importantly, so that maybe they can make that a part of their future careers to help address some of those disparities to really impact the care of the population as a whole, even more so than just one particular patient. So our new curriculum now has done a couple of things. One is, remember when I told you that I was in medical school, I learned all the normal stuff first year, and then I would learn all the abnormal things second year. Now we learn normal followed right away by abnormal, so that our students don't have that long time period between when they learn something that was normal and then they have to learn something that's abnormal. Again, we pay from day one, we pay really close attention to healthcare disparities. So Dr. Londetta Jones, who you met last week, is what we call our embedded content lead, meaning she looks at our curriculum through all 4 years to help identify areas of healthcare disparity, and talks to the students about how to identify those and to try to improve those. Importantly as well, we have a lot of early and meaningful clinical exposure, again, from day one. So every one of our courses in those first 2 years, which are traditionally, you're in the classroom or you're in the rooms talking to each other, we bring patients in so the students can meet them and can experience those patients and understand from the patients themselves what the impact of their healthcare condition has on them. So just I guess it was about 2 weeks ago, we had a wonderful patient and his wife that came in. They were brought in by one of our pulmonologists, one of our lung doctors. And the man had a long history of a really bad lung disease called interstitial fibrosis. And he was able to talk about what the impact it had on him to be unable to walk across a room without having to stop and catch his breath, or if he wanted to travel with his wife because they loved to go on cruises, he always had to think about packing oxygen tanks and packing medications and making sure that he had a contact number for his physician in case he got sick while he was on there. And then this gentleman was able to get a lung transplant, actually a double lung transplant, and he and his wife were able to talk about what that process was like, and how that really impacted their lives as a whole, their relationship with each other, their relationship with their children. And they even got to meet their donor's family, and they talked about what that meeting was like and how impactful that was for them. They actually even attended their donor's sister's wedding as part of the wedding party, which was really impactful. But as I looked around the lecture hall and I saw all these students, 150 students, all just completely mesmerized by the story that this man and his wife were telling them, I thought to myself, you know, anytime that they see a patient with interstitial fibrosis, they're going to remember these wonderful people, and they're going to understand the impact that that disease has on people, and they're going to be better doctors because of that understanding. So our curriculum is divided into two phases: the pre-clerkship phase, which again is that sort of classroom-based phase for the first 18 months, where our students really learn all the foundational aspects. So it starts with our introduction to medical school. And again, that's really more than an orientation. We really are trying to instill in them from day one things like what it means to be a physician, how to be professional, how to be humanistic, how to be somebody that cares about healthcare disparities. We start with a foundations of medicine block. So I told you that a lot of our students may take some time off between college and medical school. So this is a block that helps everybody kind of get on the same page. So it lasts about 9 weeks. Helps people from different backgrounds really get to the same level of knowledge, whether they were an English major in college or a biology major, whether they came straight from college or they took a few years to go do something else. This helps get everybody kind of up to the same threshold of knowledge. And then they get into these systems blocks. So we learn the cardiac system, which is the heart, the lungs, the kidneys, the GI tract. They learn each system sequentially and finally finish around March of their second year. There are a number of longitudinal tracks that they can opt to take. So many of our students are really want to delve into some of these other concepts along with the biomedical things that they're learning, like anatomy and physiology. So they want to learn about social justice. They want to learn about humanism. They want to be trained in medical Spanish, how to use interpreters, how to converse with patients in their own language. So they enroll in these longitudinal tracks that they do in the afternoons or on the nights or on weekends. Again, as you can see from the picture, we haven't abandoned lectures totally, but we do a lot of shorter, high quality lectures, and then we do some active learning small groups as well, all the while paying some attention to the clinical relevance as well. And once they're finished with that phase, they go into the clerkship phase. And again, this is a sort of the very traditional hospital-based part of medicine, where our students will rotate a number of different clerkships. So they'll do family medicine with Dr. Colgan. They'll rotate through emergency medicine with me. They'll go through surgery with one of our surgeons. They'll go through OBGYN. They'll go through pediatrics. All of those sort of really core building blocks of medicine. So they get exposed to a very broad amount of medicine that will help them no matter what specialty they end up going into. Now, just like it's getting harder to get into medical school, it's harder as well to get into that residency phase that I was talking about after medical school, where you train to be a specific type of doctor. So sometimes there are other sort of hurdles that they need to make themselves a good applicant. Some of that may be time for research in a particular specialty. So if you want to be an orthopedic surgeon and take care of people that have broken bones or spine problems, that's a really difficult specialty to get in. So they may want to take some time and do some specialty specific research in orthopedics to make themselves a more competitive applicant. Similarly, in a normal year where there's not COVID, they would often do a rotation at another hospital, which may be in another state where they're trying to do residency in, so that they can do sort of a month-long audition there to try to make themselves more than just an application on a piece of paper when it comes to residency. And we revisit some of these basic science concepts in the fourth year. And importantly, now residency programs are really looking for doctors to hit the ground running on day one of residency. And so we were really trying to train them to be effective physicians from the very start of their residency program. So what happened last year? As I said, we didn't really have the option to not launch our curriculum, even though there was a global pandemic going on. So we went ahead and we did start our brand new curriculum that was several years in the making, right in the middle of COVID in August of 2020. So we started really all virtual including our anatomic dissection. So anatomic dissection is when students do a dissection of a cadaver, of a body of somebody that has passed away and donated their body to science. And they learn anatomy by dissecting that body. And we weren't able to do that last year because we didn't feel safe putting students in a room together, especially clustered very closely around that. So a lot of that was done virtually. Our lectures were done virtually. We're trying to do some of these collaborative learning small groups over Zoom, which you can imagine is a little bit challenging, even if you're putting students into breakout rooms and things like that. So luckily, we were able to move to hybrid learning. We were actually able to make up some of those anatomy sessions as we were able to bring our students back onto campus. And then luckily, we were able to get a supply of personal protective equipment so that they were able to start seeing patients again. And again, as frontline workers, because they do work with patients in the hospital, our students were able to get vaccinated very early when the vaccines came, and we're actually able to get back to doing in-person learning and really helping some of our other frontline workers in the hospital with the care of patients that were here in the hospital. Now, there's our second year of the new curriculum, and we've been able to come back to fully in-person teaching. So the University System of Maryland, which is all of our campuses here in Baltimore, but also the undergraduate campus down in College Park, has required all faculty, staff, and students to be vaccinated. So all of our students have been vaccinated, and our students are currently wearing masks in the classroom as well as with seeing patients, but they are back in the hospitals and in the classrooms in full capacity now. So what does a typical day look like for one of our students? Well, again, very early in the course of getting here, we start them with their white coat ceremony. So we put on a white coat onto each one of our medical students, and we have them reflect on what that white coat means and take an oath to sort of uphold those values that they talk about when you put on one of those white coats. So we do that in the very first week that they get here to really tell them, help them understand that they are now part of a healthcare profession and have to take that really seriously. They do some lectures, and you can see here, this is what our collaborative learning room looks like. So it's students around these round tables, and there may be a facilitator here that walks through the room and helps these groups of students if they're stuck on a problem, or says, well, maybe you might want to think about this as well. They're back to doing in-person anatomy as well. And then they're back in the hospital, working with patients, helping to care for them under the, again, very close supervision of our faculty and our other resident physicians as well. And then I always say to the students, before you know it, you've gone from putting on your white coat to actually graduating from medical school. So there's an old saying that many of you have heard that the days are long, but the years are short. And that I think is very true in medical school, that it seems like a long time when you're in it, but the students, when they look back, when they get to this day where they graduate and they're getting ready to go off to residency programs, I think they say that this was a very quick 4 years for them. So that was sort of a whirlwind tour of what it's like to educate our physicians in America these days. I see at least one question in the chat or a comment. I'm thinking about becoming a doctor. That's great. That's wonderful, Zoya. I hope that you stick with that. And people often ask me if I could go back and do it all over again, would I still choose to be a doctor? And I absolutely would, because I think it's such a privilege to be able to work with patients and try to even make some small impact in their lives. So I'm happy to take any other questions they might have, and I'm going to stop sharing so that we have a little more space on my screen here in case anybody wants to unmute themselves and ask a question out loud. I've stunned you all into silence.
I just want to add, I hope I'm sure the audience is picking up the fact that this medical education thing that goes on for 4 years at the University of Maryland School of Medicine, it's not by chance, it's not by luck, it's very specifically and artfully crafted, and there's no greater leader for this than Dr. Martinez. I must tell you how grateful and pleased the students and residents and faculty are to have the leadership of Dr. Martinez, helping to guide these students on to become tomorrow's doctors.
Thank you, Dr. Colgan. That's nice. And I do see a question from Ms. Dunstan. Are MCATs still required for admission? So MCATs are still a part of the admission packet. Here at Maryland, we still use them as part of the initial screening process. They're actually not visible to our interviewers anymore. So our interviewers don't see students' grades and don't see their MCAT scores anymore, so that we do more of a holistic review of the applicant to look at things that they've done outside of the academics.
I had one question.
Sure.
If you could go back and redo medical school, would you choose a different specialty, and why?
I wouldn't actually. So I have always loved emergency medicine since I started doing it. And actually I don't practice as much as I used to because I spend a lot of time in the medical school running the curriculum now. But my days in the emergency department, I still enjoy them, and I love being there at the front door of the hospital when patients come in needing care, no matter what their condition is. I think it's a real privilege to be able to see patients, and I understand very well that for many of those patients, this is a very difficult time for them and maybe one of the worst days of their life if they have to come to the emergency department. And I think being there to be able to provide some comfort and hopefully help them with whatever has brought them to the emergency department, I think is an incredible privilege. And so I'm very grateful to be part of that. Ms. Dunstan, yes, there are scholarship programs for URMs and women, and we're always looking to increase our number of scholarship recipients. Here at Maryland, we unfortunately don't have a lot of full scholarships. We have some, but we have a number of partial scholarships. But that's been a real focus, is trying to increase the amount of money that we're able to give to individual students, so that that's not a barrier for students to come to Maryland, and that we're not losing qualified applicants to other schools that are able to provide scholarship money. Jonathan S. says, does the medical school plan on, or has the school planned on doing anything to address the epidemic of misinformation? What are some of the efforts the school takes to train students in patient education? Yes, absolutely. So the medical school and the medical center have done, I think, a lot to try to help with some of the misinformation. So we've had a number of meetings with members of the community. We put out a lot of educational multimedia in a number of different formats as well. And we specifically train our students, not necessarily around COVID, but we train our students in what we call patient-centered communication, which means communicating with our patients in a manner that puts the patient at the center of the conversation, as opposed to being doctor-centered, which is where the doctor has put their needs first, whether it's the need to gain information or the need to do a procedure or things like that. So trying to understand where patients are coming from, what their baseline level of understanding of their condition is, and helping them to be a part of their decision-making process as well. Tiffany B says, have the students adapted well with the changes? Do you feel the more hands-on approach prepares the students better than the lectures? Absolutely. So our students really have been wonderful. And again, as hard as it was for us to launch a new curriculum during COVID, it was even harder on the students to be part of a new curriculum during COVID. This was, I'm sure, not how they envisioned their medical school first year being like. But they've been very flexible and adaptable. And anytime that you launch a new curriculum or make a big curricular change, you really need a lot of information back from the students about how things are going. And so we talk to the students on a daily basis, and we have a system of evaluation of every single lecture and things that we do with them to figure out what's worked well, what could be improved, what should be scrapped altogether for the next go round. So we really pay attention very closely to how the students are perceiving our new curriculum as well. Ms. Harris says, have you
quick question?
Oh, sure.
How much of your curriculum is geared toward pain management?
So pain management is a part that spans a number of different courses, actually. So we touch on that in a number of different through the first 2 years, as well as being part of some of our third-year curriculum. And then there's an elective in pain management that students can opt to take in their 4th year as well. So it's something that, and we have several physicians here that are very skilled in pain management that have been really great about working with our students. And actually pain management is something that's now really a requirement in all medical schools to be taught. And so we're trying to do a better job with all of that as well. Ms. Harris, yes, we have had older people apply for medical school. Actually, even as far back as when I was a medical student, I had somebody in my class that at that time was 50 years old, and that was one of our older students at that time. So we certainly do have people, many of whom have had, completely different careers outside of medicine where they've been working at something else, but maybe have always wanted to be a physician and have come back and tried to follow that dream later in life. Samantha L says, does UMUC offer a holistic educational program? Samantha, I'm not sure I'm not sure that I understand the gist of the question. Maybe you can clarify a little bit for me about what you're asking with that.
And Samantha, you can feel free to unmute yourself if you'd like to ask. You don't have to type it in the chat.
Sure.
Thank you. I was trying to find the unmute button. Sorry.
It hides sometimes.
A more holistic approach is to resolving medical issues such as high blood pressure, diabetes. I know medication is very important in the process, but there's also a holistic approach to curing or aiding in dealing with those diseases. That's what I was asking.
Thanks for clarifying. I think I do understand you a little better. Yes, we do, and I think that gets us back a little bit to what I was talking about being, being patient-centered around your communication with patients, rather than simply, saying, I'm the doctor, this is what should be done, kind of imposing what you want to do on the patient, rather than understanding the patient's perspective about how they want to approach, their own health. And I agree with you that many times that's a multi-layered approach, right? So for some people, it may simply be medicine, but for other people, it may involve more than just pills, or may not involve pills at all. It may involve a lot of other things that can impact their health as well. So definitely we try to instill that in our students and our young physicians as well, because as I mentioned, learning doesn't end just when you graduate from medical school. You have to constantly keep learning. So we've rolled out this patient-centered communication even for our senior faculty member, well, because I think everybody can learn something from that as well. Hope that helped.
Wonderful, wonderful. Well, if there aren't any more questions, Dr. Martinez, we just want to thank you for joining us this evening. We thoroughly enjoyed your presentation and we appreciate your time.
I'm happy to do it.
Absolutely.
Thanks, everyone.
All right, everyone. Well, we will now take a short break. We will resume at 6:50 p.m. So feel free to get some water, stretch your legs, and we will resume with our second presenter in a few minutes. All right, we'll see you at 6:50. Thank you, everyone.
Welcome back, everyone. We will now hear from our second presenter for the evening, Dr. Michael Jablonova. Dr. Jablonova is an adjunct assistant professor within the Department of Medicine. He also serves as Senior Vice President and Chief Medical Officer of the University of Maryland Medical Center in Baltimore. Dr. Jablonova is a graduate of Duke University School of Medicine, and he completed his residency in internal medicine at the University of Maryland Medical Center and Baltimore VA Medical Center. A longtime practicing clinician educator and faculty member of the University of Maryland School of Medicine, Dr. Jablonova is a fellow of the American College of Physicians. His passions include promoting quality of care, patient safety, medical education, and driving cultural change. Here to present on navigating today's healthcare system and taking charge of your own health, Dr. Michael Jablonova.
Thank you very much, Dr. Colgan. And I'm hoping everybody can see and hear me. Lauren, can I just do a sound and video check here? Great. Well, thank you all very much for the opportunity to participate in the mini med school. It's wonderful to see this number of individuals who have signed up for what I think has always been a terrific program. And personally, I have to say it's a pleasure and even more really an honor to participate in this program. So thank you for that. And let me also extend my congratulations to everybody on graduation night. It's kind of special to be here on that night as well. And as Dr. Martinez said, I hope this series of talks has been really productive and educational for everyone on board. I should add too that maybe in contrast to some of the earlier talks before today, my presentation is not scientific or focused on a specific disease. Instead, as Dr. Colgan said, I'd like to discuss navigating the healthcare system and hopefully provide some useful tips on how you can take charge of your own health. This isn't meant to be all-inclusive, but again, hopefully some useful advice on how you can be better positioned in the future to deal with health issues when they arise or if they arise, and prepare yourself for any major illness that you or perhaps a family member may confront. So again, my name is Michael Jablonova. As Dr. Colgan said, I'm the Chief Medical Officer, which is essentially the Chief Administrative Doctor for the University of Maryland Medical Center. And I've had the privilege of serving in that role for about 6 years, but have been on our campus here at the university, a site for more years than that. And I am an adult doctor, an internist, as Dr. Colgan said, and tremendously enjoy treating patients both on the inpatient side and outpatient, although my administrative duties don't allow me to do that quite as much as before. But I've been with the School of Medicine now for more than 25 years. And again, one of the perks is actually getting to participate in a presentation like this with you all tonight. So thank you again. So let me launch into the discussion. I call this navigating healthcare land. And while that's a made-up term, it really is meant to emphasize just how big, really enormous healthcare is in the United States. It's actually about 1/6 of our total economy. We're talking trillions of dollars. And that healthcare universe is enormous, it's complex. I would say it's even overwhelming at times. Even if you work in it every day like I do, it still can be overwhelming at times. There's just so many players, there's so many regulations, so many entities, so many questions. And on top of all of that, if you're dealing with healthcare issues, there's usually some or even a lot of anxiety on top of this very sort of complex healthcare land. And so I always like to say it really, no matter whether you're dealing with a chronic disease, whether you're about to have a baby, perhaps you're receiving counseling for mental health, it can be a bit overwhelming. And clearly it's really not easy. However, I'm hoping tonight we can go through a couple points that maybe shape this a little bit more clearly for everybody, and would love to answer questions at the end of this talk. So to start, let me just talk about the different kinds of entities or enterprises that you can confront within the healthcare system. Well, certainly large academic medical centers like the University of Maryland Medical Center that you see here is one that some of us are quite familiar with. And that can be a pretty, I'd say, overwhelming place until you get to know it a little bit better. Many individuals are on multiple medications, and the world of pharmacy is really an intrinsic part of navigating the healthcare system. We treat patients who may be on 1 or 2 medications. Some are on 15 or 20. And I'm sure that many people on this Zoom call are probably taking medications too. And sort of learning about the medications, how they interact, how they can affect you, side effects, is really part of learning the healthcare system as well. Many individuals participate in therapy. That can be rehabilitation therapy associated with injury. So you may get physical therapy, occupational therapy, perhaps rehabilitation for substance abuse or alcohol abuse. So that's a fundamental part of the large system as well, that sometimes we don't think about until we're confronted with an emergency or some kind of urgent issue and require that kind of therapy. I'm sure everybody here, including me, has sat for long periods of time in doctor's offices, which can consume many hours for individuals, can be confusing at times because you may be going from one specialist to a generalist to another specialist. So thinking about how you navigate that part is also important too. And then when we talk about getting healthcare, one of the key aspects in the American healthcare system is having insurance. So some people have medical assistance or Medicaid, which I'll talk about later. Learning the ins and outs of that can also be a little bit challenging until you get to know it a little bit better. And if you're a patient, for example, in a hospital bed, trying to understand what's happening to you at that time, going through certain procedures and treatments can weigh on you quite a bit. And there's some ideas on how to navigate that better as well that I'd like to talk about too. Some people on this call may have Medicare, which is a large federal program, which I'll talk about in a second. Learning the ins and outs and the different kinds of Medicare plans is also fundamental to making sure you get the right care at the right time, really when you need it. And again, whether you're in a doctor's office or having a procedure done, again, trying to learn, what's that all about? What do I need to know? What do I need to prepare for before, during, and after? It's also fundamental to navigating the healthcare system. So to start, let me just talk about choosing a health insurance plan. It's sort of the port of entry into getting healthcare for many Americans, although about 40-some million Americans, unfortunately, don't have healthcare insurance at this time. But for the millions who are on Medicare, and if you're not familiar with it, let me just highlight a couple points. This is a federal health insurance program that was set up in the 1960s under President Johnson, and it targeted individuals who are 65 or older, as well as younger people who have disabilities, and importantly, people who have long-term kidney disease, who may be on dialysis 3 times a week or have even received a kidney transplant. And then a sister program to Medicare is called Medicaid, or in Maryland, it's called medical assistance. And Medicaid is health coverage for millions of Americans, oftentimes those who may be eligible because of low incomes. Some children are eligible, pregnant women, elderly adults, and people with disabilities. So these 2 programs, which are run out of an office actually in Woodlawn in Baltimore for the entire country, are really an important part of the insurance landscape. On top of that, what happens if you don't qualify for a state or a federal health insurance program? Most people who are working typically will have health insurance offered through their workplace, and you may be asked to choose a health plan if you're working. If you have your own business, or if you're not working, or if you don't qualify for these programs, then you may have to find a plan on your own, which can be quite expensive. But just to break it down somewhat simply here, knowing a few things before you can compare plans is important. Many insurance companies, this could be Blue Cross or Care First, Aetna, Cigna, United Healthcare, have typically 4 categories of health insurance plans, and we call them the metal categories: platinum, gold, silver, and bronze. And typically, the more expensive the metal, the more expensive the plan. And these categories tell you basically how much you're going to get for your money and how you're going to share the cost with the insurance company when you need help or need care. But it's important to emphasize that the categories, platinum versus bronze, don't necessarily have anything to do with the quality of care. It's the access to different kinds of care and what you'll pay for the care that it typically connotes. Now, your total costs for healthcare are several-fold, typically, even when you're insured. Most likely, if you'll have a monthly bill that you pay to your insurance company called a premium, and you pay that every month, no matter whether or not you use medical services or not. And you also will typically pay out-of-pocket costs, including co-payments or co-pays, which may be $10, $20, $40 when you go to see an outpatient doctor. Even though you have insurance, you pay that extra cost. You may also pay a deductible, which is a minimum amount that when you start getting care, you have to pay off those dollars first before your insurance kicks in. So as an example, say you're in the hospital and it costs $10,000 altogether. If you have a deductible of $3,000, that means you need to pay out of pocket $3,000 before your insurance kicks in. So it's important when you're shopping for a plan to think about what's the cost distribution going to be. And then finally, it's important to remember too that there's different kinds of health insurance plans. In the 1990s, HMOs or health maintenance organizations like Kaiser Permanente became very popular. There's also PPOs, which are called preferred provider organizations, POSs, point of service organizations. These are all different kinds of structures of plans where when you join, you will have different levels of access to doctors and hospitals. If you join a more expensive one of these with greater access, you'll be able to choose your doctors and perhaps the hospitals where you go to more easily than if you join a more restricted plan. So it's good to know what kind of plan you're signing up for. And they usually provide very thick booklets on what those entail. And it's important to try to understand what they encompass so you won't have any surprises. And it is important to remember that these plans actually can differ in quality. Now, when we talk about navigating the healthcare system, the insurance is sort of your port of entry. But I think what's really important is actually finding a good provider. And the term provider is relatively new. When Dr. Colgan or Dr. Martinez or I were in medical school, we didn't use that term as much, but a provider nowadays typically refers to a doctor or physician who can be an MD or doctor of medicine, or a DO, a doctor of osteopathy, which are pretty similar, or it could be a nurse practitioner. And nurse practitioners have become very common in practice now. They have special training beyond their nursing practice, and they often work with physicians, and in Maryland can act actually on their own. And what's really important is that when you're looking to establish your medical care, that you can select a good primary care provider who essentially serves as your quarterback. That becomes your point person who you typically will go to for regular checkups and follow-ups, but who also becomes a great source of information if you need referrals, say to a specialist doctor, or if you need to go to the hospital. That person becomes your source of information and can help direct you, just like a quarterback can direct a football team. So how do you actually determine who your provider should be? Well, it's important when you pick your health insurer to understand from them which clinics and providers are actually available to you. Again, in more restrictive plans, you may have a more limited choice of providers. In a very expansive plan, you may be able to choose anybody who's available to you anywhere in your area. It's also important to look at provider qualifications and experience. Look to see how many years of practice has that individual been in, and have they graduated from a good medical school? Are they board certified in their specialty, which means they've passed a very exhaustive test that proves in many ways that they have a competency to practice in that field. I think what's just as important too is to actually try to determine the philosophy of care that that provider has. In some cases, and I think it's always good to ask for this, you can actually interview your prospective provider and see if that's an individual who will listen to you, who will respect your decisions, who you feel like you can click with. Clicking with your physician or your nurse practitioner, your provider, whether that's a family practitioner, an internal medicine doctor, your surgeon, a psychiatrist, is really, really fundamental. Try to get a sense too, are you free to ask them questions? And when you do ask questions, do you feel like they're being answered to your satisfaction? Do you feel like the individual listens to you and just doesn't talk over you? I think that's really key. And then it kind of boils down to a question of, do you feel confident and safe in having this provider manage your care, prescribe medications for you, maybe perform procedures on you, or refer you to individual other physicians who may perform procedures on you and make important decisions in collaboration with you. You know, in the old days, medicine used to be very paternalistic. The doctor would say, do X, Y, and Z, and many people would say, okay, that's what the doctor said, I better go do it. Nowadays, we really aim for a much more collaborative kind of relationship with our physicians and other providers. And so making sure that you have that kind of chemistry with the individual, I think, is very important. And then finally, one last point that sometimes gets overlooked. Say you find a physician who you just think is wonderful and you want that person to manage your care. It's also important, if you live near a local hospital, whether it's in Baltimore or somewhere else, to understand if that doctor actually has admitting privileges at the hospital where you would like to go. Privileges are granted by hospitals to physicians once they are screened through many different kinds of filters. And they then enter what's called the medical staff of that hospital. So you want to know, if you find a doctor, does she or he have the ability to treat you at the hospital of your choice? Now I'd like to focus on what you can do before you even receive health care, and what you can do during receipt of your medical care. So number one, I think what's really important, and this is always easier said than done, but I do want to emphasize it, try to be informed. Clearly, I would say that everybody on this call is probably informed. You're taking the initiative to learn about medical practices through the courses in the mini med school, which I think is fantastic. So you're clearly curious and inquisitive already. With that, try to be informed about any medical conditions that you have. Try to be informed about your medications. Try to get a good understanding of what you're being treated for. So if say you have diabetes, try to look up information around that. And there's some great websites that I would recommend. The Mayo Clinic has a terrific website. If you're looking around infections, for example, and vaccines, which have been a hot topic, go to the CDC's website, the Centers for Disease Control. You can go to WebMD and many other private entities online that can provide some great information for you about different disease states. You also want to be prepared for your hospital stay. Try to get an understanding from your doctor's office if you're going in as an elective admission, and you're going in because it's not an emergency, but you need something done, either medically or surgically. Try to understand how long you're probably going to be in the hospital. What should you bring with you? Who's going to pick you up when you leave? What's going to happen after surgery? Will you need rehabilitation? What are the next steps? So trying to ask those questions is important. Knowing your medical history before you go in is really key. The more that you can share with your doctors and nurses and other healthcare professionals about your medical history and any diseases or conditions that you've dealt with or any surgeries that you've had, that makes it much more, I would say, facile for those healthcare professionals to take care of you. It's also important to know your family's medical history. Did your parents or brothers and sisters have any significant diseases? Because if you can share that with your physicians and nurses, then they have a higher index of suspicion for something if that runs in your family. So always good to share that. And as I mentioned before too, knowing your medications is key. That doesn't mean you have to know every single thing about the medications, but knowing the names or having a list of the names and what each pill is perhaps used for can be really very helpful. It gives you a sense of empowerment and knowledge that I think can be very helpful when you come into a doctor's office or a hospital. And if I can emphasize one take-home point tonight, please feel free to ask questions of your healthcare professionals. I think that is really key for navigating the healthcare system. Some people are a little bit shy about doing that, but many of us expect questions to be asked, and it really gives you the opportunity to get more information in a really, I think, a cogent way with the people taking care of you. It's also helpful to bring someone with you, if you can, many times to a doctor's office, or more importantly, to a hospitalization or the emergency room if you can. Because, you know, when any of us are sitting in a hospital bed or a doctor's office, we're hearing a lot of information. And it looks for many people is when they leave after that visit or that hospitalization, even though they've heard a lot of information, they don't necessarily remember it all. Having an extra set of ears and eyes with you, an advocate, a family member, or a friend, gives you that extra ability to capture more information. And as an advocate, they can speak up for you too if for some reason you don't feel comfortable doing that. So that really helps empower you during your stay. As I mentioned, after your medical visit or your hospital stay or surgery, it's good to know what you may be in for. Do you need follow-up visits? Do you need any further procedures? Will you need any kind of physical therapy? Those kinds of issues are important to ask about also when you're actually getting treated. So I'm going to switch now from insurance to physicians to hospitals. What can you do to actually evaluate hospitals if you have to go into a hospital for an emergency visit, perhaps, or more with more time in advance, perhaps for an elective medical or surgical admission? Well, one good resource is the Centers for Medicare and Medicaid Services, or CMS, patient satisfaction scores. The Centers for Medicare and Medicaid Services is the federal agency in Woodlawn that actually runs, again, Medicare and Medicaid. And you can just go on the web, you can Google this. This happens to be the website where it actually will tell you how other patients who have been treated in that hospital have felt about the care they received. And it's called Hospital Compare, and it can tell you, did many people feel like the hospital care from the nurses was good? Did the doctors communicate with you well? Was the hospital quiet? Was it clean? Were you given good information when you were discharged? Using that kind of information can really make you more informed before you go to a hospital. There's also another program that actually focuses on doctors' offices, very similar to this. It has an acronym called CGCAPS. But if you look up patient satisfaction in ambulatory doctor offices, you can actually look up medical practices to see how other people who have been treated there would rate the experience they had. So that gives you the power of information before you even go in. It's also important when you look at hospitals to see what kind of specialties are offered there. What kind of specialized services might they provide, and how much experience do they have with select procedures? I always like to say, if you have a Chevy for a car and you go to a mechanic who deals with Chevys all the time, that's probably where you want to be. But if you have a Toyota and that mechanic never works on Toyotas, you probably don't want to bring it there. Well, it's the same thing. Say you need cardiac or heart surgery. Say you need bypass surgery. You want to choose a hospital that does that a lot, because more experience typically translates into safer, higher quality care. So it's important to look, is that something they do at that hospital a lot? Or if not, perhaps look around a little bit more. And then online through CMS and other organizations, you can find quality and safety reports about the hospitals that you're looking at. And that can tell you, how often do people seem to get infections there? How satisfied are people with the care that they receive there? Were people discharged and then turned right around and got readmitted back into the hospital? You can find those kind of data pretty easily online. And the more you research that, I think the better you are prepared when you go into a hospital. You also want to understand the costs. Based on your insurance, your cost at one hospital may be very different from the costs at another. In one hospital, for example, a hospitalization may cost $30,000, and your insurance may only cover a small part of that. In some other hospitals, the insurance may cover a very large percentage and leave you with only a little bit to pay. So understanding from your insurance company and the hospital billing office how much you might pay before you go into the hospital is important, so there's no bad surprises at the end. And then I would also say it's important to determine, Are you going into a teaching hospital or not? So where I work at the University of Maryland Medical Center, we are a teaching hospital. We have about 1,000 doctors in training. We have hundreds of medical students that you heard Dr. Martinez talk about who come through. I think that creates a very exciting kind of atmosphere. And typically, there's a lot of expertise associated with hospitals like that. But it also means that you may have a lot of medical students and doctors in training knocking on your doors at night and maybe disrupting your sleep. So you have to decide what's worth it. Is it that expertise associated with a teaching hospital? Is that really what you want? Or do you want a nice sort of quieter hospital where you may not have that same level of interventions from students? And that's sort of a philosophical question that everyone has to answer on their own. I would add again then too, to come back to the same theme, when you're in the hospital, be sure to ask questions of your doctors, your nurses, the pharmacists. And if you're not getting questions or concerns or complaints really addressed satisfactorily, almost all hospitals have a patient advocate. You can always ask for the patient advocate. That's a neutral third-party person who can come speak with you and your family and try to help you navigate any problems that may be arising that aren't getting addressed as well as you want them to. Now I'm going to switch gears for the last 10 minutes or so here and talk about how you can take charge of your own health and well-being, which I think is critical for all of us. First of all, I would ask, why would you take charge of your own health and well-being if we have such a good healthcare system? Well, number one is the experts can't fix everything. You know, the doctors and the nurses and the pharmacists and the therapists, they can take care of a lot, but 70 to 80% of the care for somebody is really their own self-care and really trying to make sure that you eat right and that you follow good practices and don't smoke are kinds of things that can be really position you better down the road. You have to take charge of that. Also, taking charge of your own health is important, and acting on things early is key. If you have an issue or a concern or something you're worried about, the more you delay it, the more chance there is of something becoming worse down the road. So addressing that early on and taking charge is the best way to really prevent problems from becoming big problems. And remember, the healthcare system isn't perfect. We strive every day to eliminate any kind of preventable harm, but there's not 100% guarantee of that. So when you take charge and your advocate perhaps takes charge with you, you can help shape your care even more effectively, working in tandem with your doctors and nurses. You also deserve satisfaction, in the care that you receive. So it's important as a consumer. Patients are really consumers to take charge to make sure that you're getting full satisfaction with what you expect to get in terms of your health care. And it's important too, again, to always explore all of your options. If you have a certain kind of condition, again, many people go online, they speak to friends, they call support groups to find out where's the best place to get that kind of care. Maybe it's in Baltimore, maybe it's not. And if you have the option, going to the place that really knows that condition the best or does the most procedures that you need can sometimes be an advantage. So how can you become a more informed consumer of healthcare? Well, again, you want to know your provider options, which I touched on before. It's important also to know some of the basics of public policy and healthcare laws. A couple of examples. Nowadays, and this is relatively new, you have almost unfettered access to your medical records that your doctors have actually created. So if you want to see your medical records, you can access those except in some very select cases. There's also privacy laws called HIPAA that prevent information of yours being shared with other people who shouldn't be seeing that kind of medical information. So it's good to know that kind of policy as a consumer advocate. Again, you also want to know what your treatment options are. You want to be able to seek help when you need it. And again, coming back to an advocate, important to be able to have an advocate with you to help improve your care and to speak up for you if for any reason you feel that you can't do that. I would also emphasize too the importance of resources. Various institutions have community health education centers. The Midtown campus now of the University of Maryland Medical Center has just opened this in a big new building. That can be a great resource to go and learn about different conditions and get questions answered. Health fairs, whether they're at the mall or in other places, can be great places to actually get checks done to see perhaps, do you have a tendency towards diabetes or high cholesterol? And the websites, some of which I mentioned, again, respectable websites can be very helpful in providing information that can really make you a more informed consumer of healthcare. It's also really important too that you keep track of your health information. I like to suggest that people keep an electronic or a physical folder of all of their healthcare information so that you can access that easily and see which doctors have you seen, what procedures have you had, when did you receive vaccines. Keeping that all in one place can be really helpful. My wife and I try to do that at all times because otherwise it can become really challenging. As I mentioned earlier, knowing your family's health history is important too, because that can help shape the kind of care that you're going to receive. I always emphasize too, seeing a doctor regularly for checkups. Some people recommend once a year, some people a little bit less often, but those checkups are important times, particularly with your primary care provider, to bring up concerns, to be checked routinely for specific conditions, and to raise any questions that you may have that have been bothering you that you need to get answered. Being prepared for those medical appointments is key too. Many of my patients typically would bring a list of questions. Now, you may not be able to get them all answered all at once, but to have a list really provides you a basis ahead of time to have questions at the ready that you can share with your provider and hopefully get answers to your questions in real time. As I said, asking questions of your doctors, your pharmacists, your nurses, really very, very important. I would also emphasize just how significant following up after your appointment is. You know, you may see a doctor for one thing, and then he or she may say, I need to see you down the road. Keeping those appointments is key. If you have high blood pressure, if you have diabetes, if you have asthma, for example, following up with those regular appointments is important. If you've had surgery, following up with the surgeon afterwards to make sure everything looks okay and there's no signs of infection. And taking your medications as prescribed and taking the tests that you are recommended typically are also very, very important. Because if people aren't compliant with their medication or testing regimen, if they don't take ownership for that, it's very hard to direct the care and take care of yourself. So really being compliant is fundamental to making sure that you stay in as good health as possible. And then 2 more slides here. It's also important that you comply not only with recommended health screenings, but vaccines too. So we talk about health screenings, and for adults in particular, there's certain screenings, especially for diabetes, cholesterol, and cancer, such as prostate cancer or gynecological cancers or breast cancers, that we recommend on a very premeditated basis. Catching something early is always better than catching it late. And getting vaccines that are recommended. There's been a huge amount of discussion about the COVID vaccines, and I hope and I will strongly encourage everybody, if you haven't gotten that, please consider getting it, and the flu vaccine. But there's also pneumonia vaccines for certain individuals, diphtheria vaccines, shingles vaccines. Important to ask your doctor about those too, because the more vaccinations you can get for these that are recommended, the more you can ward off diseases down the road. The other thing I would finish up with here is seek out support groups. Support groups can be wonderful because they bring people together who are going through or have gone through similar experiences. That might be cancer. That might be a chronic medical condition like colitis or diabetes. It might be bereavement after someone's death. And the support groups typically provide opportunities for individuals to share their experiences, their feelings, their coping strategies, and to share with others and to learn from others how people got through what they're all going through now or have gone through in the past. It kind of fills a hole too with the need for emotional support. Talking to people who have gone through something that you're going through, even though family and friends can be very supportive, speaking to people who have gone through it too and know what it's like, that's really key for getting you through some tough times. And let me just leave you with this last slide. What else can you do? I always emphasize to my patients maintaining a healthy lifestyle as best as you can, with as much help as you can. So trying to keep your body weight to where it's recommended is key. Following a good diet, not so much carbohydrates, not so much salt, more focus on protein and fish, for example, and olive oil and fruits and vegetables and grains can be very helpful. Doing physical activity under the guidance of your physician or other provider is really key. Walking several times a week is great. Other exercises is great. The more you can do that, the better shape you're in physically, but also oftentimes mentally too. Getting enough sleep every night critical. That can be tough for many people, but it's recommended getting 7 to 8 hours of sleep. Not getting enough sleep typically can contribute to problems down the road. So really trying to give yourself enough time for sleep if you can is key. Avoiding illicit drug, substance abuse, and alcohol abuse is key. Doesn't mean you can't have alcohol once in a while, but avoiding significant abuse is important. Trying to find ways to reduce your stress through hobbies, through friendships, through volunteer work, etc., can be really important. And cultivating your personal relationships really enriches your personal environment and really gives meaning to life. The more you can focus on those things, this is really, I would argue, a more holistic approach to taking care of yourself. I think the better off you'll be physically, mentally, and emotionally. And that's where we want everybody to be. So I'm going to stop there and stop sharing my screen. And if we have time, I know graduation is coming up, but I'd be delighted to take some questions if that's still possible.
It's very, very helpful that. And I know I try to do a lot of things what he says.
Huh? I'm sorry, did you have a question? Does anybody have a question they want to put in the chat box, or certainly feel free to unmute yourself too, either way, whatever you feel comfortable with.
I had a question.
Yes, please. On.
So the United States is the only developed nation that doesn't have a universal healthcare system. And do you think that this country will eventually progress towards a universal healthcare system, or do you believe that that type of healthcare system is not within our scope of possibility?
That is a fantastic question, Zoya, and we probably need several hours to address it, but I love the question. Personally, I sometimes look at other countries in the Western developed world and Japan too. You look at Canada, you look at Western Europe, Japan, that have some, in many cases, some excellent insurance approaches to their population where there's much more universal coverage. Many of those countries also have better overall outcomes than we do. And they spend only about half of what we spend. So I think if you just looked at it from that vantage point, I think there's sort of an abstract argument that would say, you know what, we probably should look at that. I would argue though, and I know President Obama tried to move forward with this and various presidents have tried, I think there's some uphill battles in the US in trying to establish universal health care for political reasons, and particularly as we've gotten so polarized, unfortunately, in the political community, it's probably going to be a long time before we see that. Although I think there's significant merit in considering if one day we could move to it. So that's a wonderful question, and I'd love to talk more offline about it. Thank you.
Oh, and I actually had something to add on to that.
Sure.
Do you think the pandemic has exposed the issue of universal health care in the United States?
It's another really good question. I think it's highlighted to some extent the disadvantages of not having universal health care. But I think it's more complicated than that. Again, I think because society has become so polarized and COVID has kind of fed that in the debates over vaccines, it becomes a pretty complex question. But I think it actually has highlighted it a little bit more and would absolutely fuel the debate over whether or not we should have universal health care or not.
Thank you.
Sure, great questions. Thank you. We're running up against graduation, so I want to be really careful here. Lauren, do we have time for any more questions?
We do. We have time for another question or two, so we'll wait for another second or two. And
while we're waiting, I want to just jump in and just remind our audience of what we have here in Baltimore. The School of Medicine and the hospital were one entity back, I think, prior to 1987, and then became two different distinct entities. I often think of the medical school and the medical center as one of the greatest gems in the state of Maryland that so few people know little about. And I just want to remind us all that, the hospital together with the medical school, the hospital, shock trauma, was pioneered the whole concept of the golden hour that now is a concept all throughout the world. The Greenbaum Cancer Center is one of the leading cancer centers in the United States, if not the world. maybe a few of you know, but really one of the founding institutions for infectious disease in the United States is the University of Maryland Medical Center, and Dr. Theodore Woodward, and thereafter many ID doctors who came here. Our hospital for our children's hospital, it takes care of children. The COVID response, I could go on and on, but I just want us to recognize and remember what we have here. And I'll talk in a few minutes about the medical school as I get ready to say some words about Dr. Reese, but I thought I'd mention this with Dr. Jablonov on there, just to remind us about what an incredible asset we have, on Green Street and Packard and Lombard, that's really providing care for just such a large number of people in a high quality way.
Dr. Colvin, I think that's extremely well said. Thank you for bringing that point to the table.
Sometimes what you have in your own backyard doesn't get recognized as much. But I don't. The other thing I was going to mention, I don't know if people know this concept, but a small little hospital like in Berlin, Maryland, that might be called a primary hospital, or a 20-bed hospital out in Arizona might be called a primary hospital. A little bigger hospital, maybe 60 beds or 80, might be a secondary hospital. Maybe a bigger hospital like, I don't know, Suburban, or maybe even St. Joseph's Hospital might be called a tertiary hospital. It has a lot of stuff. But what few people know in Maryland is that there's only two, if I'm not mistaken, Dr. Jablonov, but only two quaternary care hospitals. That means it's a fourth level, and that's University of Maryland Medical Center, Medical Systems, and Johns Hopkins. So this hospital here is the hospital that other hospitals from around the region send their sickest patients to. Why? Because we have, frankly, almost all of the specialists who are here either 24 hours a day, 7 days a week, or they can get in here within 20 or 30 minutes. So that's how special our hospital system is.
Wonderful. It actually looks like we did get a question that came in through the chat by Ms. Butler. I don't know if Dr. Jablonov or Dr. Colgan, if you'd like to take that.
Yeah, I just started trying to respond in writing, so thank you. It's what do you suggest if you've been an advocate for your health, but still have not been able to get a diagnosis for long-term chronic pain? And also, terrific question. And there's so many people who unfortunately suffer with all different kinds of pain and pain syndromes. One thing that I recommend is, you can always start, of course, with your primary care doctor, but there is a subspecialty within anesthesiology and physical medicine that focuses specifically on pain, the diagnosis of pain, and the vast treatment options that are available for pain. And I think particularly if someone isn't getting the satisfaction or the relief associated with pain, seeing somebody who specializes in that field, and it's a very distinct field with specialized training, I think is important to try to access. And you'll typically find a number of people in every major metropolitan area who have extensive training and experience in pain-centered syndrome specifically. So that's what I would recommend to start.
All right, wonderful. Well, looks like we have one more question that came in. I think we have a minute to answer that.
Oh, that's a really nice question too. It's funny because this is something I did as a pre-med student when I was in college, and we had a formal program at my hospital where I was at university. There's different kinds of opportunities, and I don't have time probably to speak to all of them today. Typically, even though we don't have a formal program per se, there's oftentimes many individuals who are working in the hospital. They could be administrators, clinicians, physicians, others who actually can mentor individuals in a sort of a pre-med hospital experience. And we do that periodically. And if there's something that I can help with, please, Lauren, I don't know if my email can be provided to the group, but or I'll just type it here.
Yes, feel free to share it with everyone in the chat.
Yeah, I'm happy to try to help with that if there's a real burning desire for that. I think it's great to get that kind of experience, and also just really to test the waters to see, hey, is this the environment I really want to train in, or I want to work in and want to live in? So there are various opportunities. It's just not all consolidated under one label, so to speak.
Wonderful. Wonderful. Well, Dr. Jablonov, we thank you for your time this evening. We thank you for staying on for a few extra minutes. to answer all of these burning questions that have come in.
Well, my pleasure. Thank you for the opportunity. And I want to congratulate everyone else on here too for graduation tonight. It's been a privilege speaking with you. So thank you.
Thank you. All right, well, it is now time to move into our virtual graduation presentation. We will begin with a special presentation in honor of our Dean here at the School of Medicine, Dean E. Albert Reese. Dean Reese has announced his retirement, and he'll actually be stepping down next year after 16 years here at the School of Medicine. So he will be stepping down from this position. However, he does plan to continue his work as a professor, a researcher, and actually heading up a new center. So Dr. Colgan will now present Dean Reese's Certificate of Appreciation.
Thank you, Lauren. And before I do so, I just want to say a couple words about the School of Medicine that you may not be aware of. You know, the University of Maryland School of Medicine is in the 3rd century. It was chartered in 1807 as the first public medical school in the United States, and it continues today as one of the fastest growing top-tier biomedical research enterprises in the nation. Our faculty includes members of the National Academy of Medicine, the National Academy of Sciences, as well as a distinguished 2-time winner of the Albert E. Lasker Award in Medical Research. As one of the 7 professional schools that make up the University of Maryland Baltimore campus, the School of Medicine has a total workforce of nearly 8,500 individuals. The School of Medicine works closely and in partnership with the University of Maryland Medical Center. You just heard from Dr. Jablonova, the medical director of that institution, and with the University of Maryland Medical Center and medical system provide research-intensive academic and clinically based care. The School of Medicine has reached $563 million in extramural funding. I mention all this to say that, again, this is one of the things we probably don't recognize about something that's right in our backyard. Our School of Medicine faculty ranks as the 7th highest in the nation amongst public medical schools when it comes to research productivity. So all of this couldn't happen without leadership, and that leadership has been in the form of Dr. E. Albert Reese for the past 16 years. Clinical care is paramount to Dr. Reese, and we have increased clinical visits, doctor visits, manyfold in the course of his time here. Research funding and grants and scholarly activities has been really key in the agenda for Dr. Reese. And not only that, but community engagement and impact has been important. That's what many medical school it falls under, so to speak. This is a community engagement and impact initiative. Another one is the Maryland Area Health Education Centers that I serve as the program director for, which provides outreach to underserved areas in the state by bringing in educational resources to them. So I say all of this to build up my next couple of words, which is a presentation to Dr. Reese, who we'll miss dearly. He's been a fantastic leader for our institution, and we're glad he's not leaving. So let me show you first the certificate that we have for him, and then I'll read to you the words that are on there. There it is, nice and snazzy, suitable for framing, right? I'm sure this is one of many, many that he could put on his wall, but I'll read it to you right now. And it says, on behalf of the University of Maryland School of Medicine Honorary Certificate of Appreciation to E. Albert Reese, MD, PhD, MBA, on behalf of the entire University of Maryland School of Medicine community and all of the past and present participants of the University of Maryland School of Medicine Mini Med School program, in recognition of your unwavering leadership, commitment, and support of Mini Med School over the past 16 years, in honor of the dedicated service and important role you have demonstrated on behalf of the University of Maryland School of Medicine, and in recognition of the tremendous impact you've had on the citizens of the city of Baltimore, we are pleased to confer upon you this honorary certificate of appreciation signed by myself, Christopher Hardwick, the Associate Dean of Public Affairs and Communication, and Ms. Lauren Robinson, Public Affairs Community Health Specialist. So a round of applause for Dr. Reese, and our greatest thanks to you, Dr. Reese. So before we hear from Dr. Reese, I'd like to introduce a very special guest, Dr. Destiny Martin. Dr. Martin is a family medicine physician at the University of Maryland. She's a resident in training in our family medicine residency program. She's also a proud graduate of the University of Maryland Mini Med School program. That's right, you heard me correctly. She was once sitting where you were years and years ago. She sat where you're sitting right now as a Mini Med student. Dr. Martin is fortunate to call Baltimore home. She was born and raised in the city of Baltimore. She went on to attend college at Johns Hopkins University and graduated pre-med with a degree in public health. A year later, she received a master's degree from the Johns Hopkins Bloomberg School of Public Health. Dr. Martin went on to do missionary work, then later returned to Hopkins to participate in numerous clinical research projects, including the TALK study, the PREPARED study, and the HOPE project with the Center for Adolescent Health. She also spent time volunteering at the Family Tree of Maryland and working at the League for People with Disabilities. After she attended medical school, she spent 1 year at the University of Maryland with the Department of Pulmonary and Critical Care before beginning her residency in family medicine. This is currently her second year working as a physician in the community she loves, with the people she loves. Dr. Martin, would you like to share a few words about your mini med school journey?
Hi, Dr. Colgan. Thank you. I would love to. My name is Dr. Destiny Martin, and it's a pleasure to meet all of you today. It's a pleasure to meet all of you today, and I want to say thank you to Dr. Colgan and thank you to all of you who made this possible. And I would especially like to say thank you to Dean Albert Reese, for making programs like the University of Maryland Mini Med School possible. As a young woman, it was a privilege for me to come and be able to learn and sit in one of the auditoriums where I envisioned myself one day practicing. What I really liked about the program is that we focused on healthcare issues that were important to the entire community. And we did it in a way that was interactive, that was stimulating and thought-provoking. And a couple of years ago, we did it in person, and I really loved that, but I love that we can still do it virtually. I like that we learned about health literacy, and that was something that I really appreciated. It taught me how to advocate for myself as a family member, but also like just as a patient. It taught me those things. So I really appreciated that. Programs like this are valuable, especially in a country where 9 out of 10 adults struggle to understand and use health information. So I love that we're learning about health literacy. That was one of the things I really enjoyed about the program. So this program motivated me to be more engaged in my healthcare, and it also opened up the possibility of me pursuing medicine in the future. In September, I actually had the opportunity to speak at the Mini Med School for Kids. And I really enjoyed that session. It was excited to see the next generation interested in learning about medicine and the human body. I looked at them and I remembered myself at that age. So Dr. Reese, thank you for the time you invested in our community and children and young adults and older adults as well. And thank you for encouraging young people such as myself to consider medicine as a possibility. So it's an honor and a privilege to present this award to you today. So thank you.
Thank you, Destiny.
I've stopped the video. I'm under the impression that some folks can't hear. Dr. Colgan, could you confirm, are you able to hear?
I was not able to hear, no.
Okay, all right, let's try this again. Please excuse the technical difficulties. Let's give this another try.
Got one more. But you know what? You gotta do that again. One more. Trying to figure out what can we do? How can I help out this time? You know what I mean? What can I do? Right. Because I know a DJ. He better than DJ Tuesday. And I can help out with a lot of stuff, man. Next time we do something, let's try to do something for women. You know what I mean? Yeah.
All right, can everyone see this recording? All right, I'm gonna press play and let's see. Give me a thumbs up if you can hear.
Much, Dr. Martin. You are truly a testimony to how successful our mini medical school program has been over these many years.
Is everyone able to hear?
Yes, but someone needs to mute.
Yes, okay. All right, if anyone is not muted, please be sure to mute yourself so that everyone can hear the recording. Thank you very much. All right, looks like we've got things going now. Let's try this again. Thanks for your patience.
Thank you very much, Dr. Martin. You are truly a testimony to how successful our mini medical school program has been over these many years. We are so proud of you and everything that you have accomplished. I'm honored to be presented with this certificate of appreciation. Mini Medical School has been one of our most impactful programs at the School of Medicine for the past 21 years. And I know it will continue to grow even stronger in the future. I am deeply grateful to Dr. Colgan, our faculty presenters and program coordinators who have contributed to making this program what it is today. Most importantly, I'm thankful for each of you. It is because of your participation year after year that you are growing in your knowledge and your understanding and how you can improve your health and well-being. Hopefully this information is being shared with your families and your friends, at the same time helping to build a healthier and brighter future among the residents of this great city of ours. Let me say once again, congratulations to each and every one of you for this in this year's graduating class. May God bless you all. I know that many of you have participated several years, maybe every year, and I want to thank you and congratulate you for your commitment to this program. I know in this year's sessions, you've learned so many valuable information on health screenings, COVID-19 vaccine development, mental health, palliative care, sleep medicine, blood disorders, and more. We hope that all of this information is useful to you in helping you and your family and friends be as healthy as you possibly can. In this respect, I have two requests to make of you. The first, please fill out your survey and let us know how we can make the program better. Also, let us know the topics you're most interested in, and we'll see if we can address those in next year's program. My second request is as follows. Spread the word. We want to attract as many new participants as possible next year and every year thereafter. I encourage you to recommend a family member or friend who can add to your list for next year. If you can think of anyone, please email that information to Ms. Robinson at the end of today's program. Once again, congratulations, graduates. I'd like to turn the program over to Ms. Robinson this time, but I just once again want to wish you all the very best, and may God bless each one of you as you try to live a healthier life every day. Thank you.
There we go. Thank you so much for your patience. That was our very special recording from Dean Reese. Unfortunately, he was not able to be here in person tonight. However, he did take time to record a very special congratulatory message to all of our graduates. So at this time, I would like to just give a special thank you to our Executive Director of Mini-Med, Dr. Richard Colgan, as well as Dr. Destiny Martin. Thank you so much for joining us this evening. And I'd also like to thank all of our faculty members who joined us over the past 5 weeks. And especially we have to take time to congratulate all of you. Congratulations on your successful completion of Mini-Med School. That's a very, very exciting accomplishment, and you have a lot to be proud of. So congratulations to you. So I'll go ahead and close with a few announcements. Please remember that graduation certificates will be sent to participants who attended at least 4 out of the 5 sessions. So we will send them to participants via the email address you used to register for the program. So we will be able to have these to you by next Tuesday at the latest. So please be sure to check your email next week. Also, please be sure to use today's evaluation link. We would love to have your feedback, not only on our presenters tonight, but also we would love for you to share your feedback on the past 5 weeks. And we'd also like to hear what you would like to hear discussed next year. So please be sure to leave those thoughts for us in the comment section. All right, well, I will be sure to place that link in the chat at the end of the discussion. And again, congratulations to you all. I'd like to thank everyone, and we look forward to seeing you again next fall. Have a great night, and please be sure to have a wonderful and safe Thanksgiving holiday next week. All righty, thank you so much. Good night, everyone.